Welcome to Hope One Live, ladies and gentlemen. I'm Frank Turek, and we need an update on the coronavirus situation. Not a sensationalistic update, but an update based on the facts. If you're watching cable news right now, you've got to be pretty spooled up and pretty spooked about what's been going on. But I think many of the cable news networks obviously have an agenda. And one of the agendas, of course, is to get people to watch and to raise advertising revenue and that kind of thing. We're going to try and stay away from the sensationalism today and talk about just the facts as we know them regarding the coronavirus. And for that, I'm having my friend Dr. Daniel Eichenberger come back on the program because he's been a shot of sanity in a sensationalistic situation. And he's been on the show before. He's been a hospital CEO. He's been a doctor for over 30 years. He's been treating coronavirus patients. So let's get the true nature of the situation from Dan and his perspective. So let's bring Dr. Dan on right now. He's coming to us from Indiana. Dan, how are you this morning?
I'm good, Frank, and it's a pleasure being back with you.
Oh, it's always great having you on. You know, I've gotten such great comments from people who listen to the podcast and watch the Hope One show that you're bringing a lot of sanity to people who are really spooked by what they're seeing on TV and online all the time. So let's kind of get an overview. And let me just start. I know you've had some coronavirus patients that you've been treating over the past month or two. Give me an update as to how they're doing now and what kind of treatment are you bringing to them?
Sure. So the patients that I've treated have all gone home. They've done well. Currently at the hospital, we have 22 patients in non-ICU rooms, and we have 2 patients left in the ICU. So that's a huge improvement. We had several patients in the ICU, both in the what we call the critical coronary care unit and the ICU unit. And so they've all done well. So we're seeing a decrease in the incidence and the prevalence of the patients, and they seem to be doing well. Standard treatments you hear about on the news, and all are remarkably well.
Okay, excellent. Now, what's the current state, do you think, in the country? Have we really flattened the curve? I mean, that was why we were told we had the lockdown, we need to flatten the curve. Has that happened?
It's definitely happened, and the reason we wanted to flatten the curve was to not overwhelm the hospital systems around the country. And what we've seen is we flattened the curve so much that a lot of hospitals are struggling to keep the doors open and pay bills because their census is about half of what they normally should be. In a hospital our size, we 2 hospitals I familiar with and work with. One has 240 beds, and our census is a little over 100, and the other has 200 beds, and their census is about the same. So we have units that are shut down. We have nurses that are furloughed. We have administrators who are taking cuts in their pay. We have physicians who aren't taking paychecks. So it's significantly not only flattened the curve, what the social distancing has done, and what we didn't, I think, realize was how much of an impact it would have on all the respiratory viruses we see this time of year. So we're not seeing admissions for nearly as many of the other respiratory viruses just because of the social distancing.
Well, that's kind of a good outcome. I guess we didn't anticipate, but it's created this other problem for the hospitals because you don't have any elective procedures anymore, do you?
No, hospitals are struggling, and a lot of small hospitals who had very tight margins to begin with are going to close down.
So that's an unanticipated consequence of this. We'll get to the policy implications later on what we ought to, where we ought to go from here with regard to that. Have we flattened the curve in New York? The worst spot, obviously, seems to be New York, New Jersey. How taxed are they right now, Dan?
Well, so if you look at their numbers, they certainly have a decreasing number of cases, certainly a decreasing number of hospitalizations. Not as many ICU beds are taken up, and they certainly have a capacity for ventilators and other things that we originally thought was going to be a burden has not turned out to be the case. The field hospitals are not seeing as many. The Navy ship certainly is not admitting very many patients. So yes, we've definitely flattened the curve. We definitely turned the corner in New York as well.
Now, there's an article that just came out an hour or two ago on Fox News talking about how the spike in deaths has fallen off We have many fewer deaths today or yesterday than the previous day, and I guess the peak happened a few days ago. However, as you read that article, you discovered that something in the article was not told to us. What was that?
Sure. So a week or so ago, the CDC changed the rules on reporting. So now hospitals and other statewide entities can report presumptive coronavirus deaths. So, in other words, you may not have a definitive diagnosis of COVID, but if there's a high incidence of suspicion, you can still report that as a COVID death. So we saw a tremendous spike in New York's numbers in one day, typically because they were reporting presumptive COVID deaths as well.
Why do you think they're moving the goalposts in the middle of the game, Dan?
It's hard to say, Frank. As I've said before, I think there's an underlying narrative that we're not being told. I think there's three aspects to this: the political aspect, the financial aspect, and the medical aspect. And I think we don't always get told why those assumptions and why those changes in policy have been made.
Say those three aspects again.
We have the political aspect, the financial or economic aspect, and the medical aspect.
Yes, true. Yeah. And I think people that had, and I don't know their motives, I'm not here to judge anyone's motives, but obviously people that had these inflated numbers in their models are now trying and figure out a way to explain why we haven't seen the number of deaths that were originally predicted by the models.
Well, if you remember, if you remember when the original model came out, the number was around 2 to 2.2 million Americans would die from coronavirus. And then that number got substantially decreased over time. Each week it seemed like it was going down. The most recent was 100 to 250,000, and now they've decreased that number again down to 80, and I think even down to 60,000. We're right now, we're right now at about 42,000 deaths in the United States. But again, some of the other interesting things we found out from New York was one of the studies that came out from the New England Journal of Medicine. They started screening all pregnant women going into a New York hospital. And what they found, they tested 215 women, and 4 of them had symptoms consistent with coronavirus on admission: fever, cough, whatever it might be. And those 4 were positive. The interesting thing was that out of the other 211 patients, a number of those were positive as well with absolutely no symptoms. So we know that the incidence of this disease is a lot higher than what's been reported. In fact, 1 out of 7, I mean, for every 1 positive patient, there were 7 positive non-symptomatic pregnant women in New York. So the Stanford study that came out last Friday also revealed the similar, anywhere from 50 to 60% or more of patients tested positive who are asymptomatic. So that's going to considerably change the metrics of how we're measuring coronavirus deaths and the death rate.
Well, I did want to ask you about that Stanford study. As you said, it came out on Friday, and I think they surveyed people in Santa Clara County, which I used to live in Santa Clara County, right there near Moffett Field, California, San Jose area. And what did they find in that study, Dan, that will change how we view this disease?
So the study actually, from my understanding, it hasn't been peer reviewed yet. So there is going to be some critique on the study itself. And one of the there will be some selection bias because they evidently used Facebook as a means to solicit patients for the study. So that number one, you have to be on Facebook. So that's a bias. Number two, the patients are electively being tested. In other words, so some of those may have been symptomatic or not, or concerned about it. So there is some selection bias to begin with. Unlike the study they did, I think up in another part of New York, where it was just a random sample out in the open public, that they just kind of grabbed people. But the Stanford study did show that out of the people tested, they were a significant number of asymptomatic patients who tested positive. which means that they were exposed at some point, developed some antibodies, whatever. But we know that the incidence of this disease is a lot higher than what's being reported. So the death rate is going to be substantially lower than what we originally have been told.
So that would seem to me to be both good news and bad news at the same time. It's good news because if you get coronavirus, you're much less apt to die from it, because a lot of people have it, a lot more than we think, and that would mean that the death rate would come down. The bad news is it would seem that the transmission rate is high, or higher than we think. What do we know about the transmission rate right now? How many people does one person tend to infect? You originally, on the last broadcast we did, Dr. Dan, you talked about the fact that measles was what, 12 or 18?
18.
Every one person has measles, infect 12 or 18. Where do we stand on coronavirus now? Do we know?
We still don't know the answer to that. The estimates are still between 1.8 and 2.6. So again, it's still more contagious than normal influenza, and that's because it's a novel new virus. It's certainly less contagious than what we saw with SARS-1, the MERS virus, and certainly things like Ebola and measles and some of the other diseases we've seen.
So in your view, given the data that we have now, and this is probably one of the reasons why the estimates or the models have been wrong, in your view, what's the range you think is the right range for the death rate, probable range? Right now, if you just go to the number dead and number infected, you're going to say it's what, maybe 2%, but it's probably not that. What do you think it is?
I think it's going to be probably 1% or less when everything is combined and we get an accurate number of asymptomatic patients who've been tested with antibodies and things. I think we're going to see it in the 1% range.
Now, how long is a person who gets coronavirus, how long is that person contagious to somebody else?
Well, we still don't know the answer to that. We don't know if they're contagious before they develop symptoms. We think they are, but certainly we think that as long as they have a fever, they're probably still contagious. So we usually use the rule of thumb that you need to be 24 hours without a fever and minimal symptoms to not be contagious, and that can last anywhere from 5 to 10 days for the most part, for most cases.
But if someone has recovered from coronavirus, it's like, suppose I had it and I recovered. Could I give it to you long after I recovered, or is that not possible? Or do we not know?
We don't know for sure, but based on all the other viruses we do know about, that's very unlikely to occur. So unless this is brand new, this is this coronavirus, that would be a very unlikely scenario.
So with regard to this coronavirus, if we're going to treat it like other coronaviruses or anticipate its behavior, so to speak, according to other coronaviruses, the warmer weather is going to help us, correct?
Correct.
And the fact that once you get it and you're recovered from it, you're probably not going to get it again, correct?
That's correct.
And you're probably not going to be able to pass it to others after you've recovered, correct?
That's correct.
Okay, so in order to get what's known as herd immunity, maybe you should, for our viewers, describe what herd immunity is and how do we get herd immunity the safest possible way?
Sure. So herd immunity refers to the ability to infect enough people in a population that the amount of unaffected, unimmunized people are low enough that they won't be exposed to someone who could pass them the disease. So basically, immunity is related to passive and active immunity. Active immunity is what you develop when you get a disease and you build your own antibodies. You develop what we call active immunity. Passive immunity is what you are given through immunizations or through something like the serum they've been talking about from patients who've had the disease, and they inject them with plasma basically to give them artificial antibodies they didn't make on their own, but it's helping protect them. So you combine the two, and if you get enough people in a population to have that antibodies in their system, then you develop a herd of people that won't be able to not only get the disease, but then pass it on to others. So when you get a substantial amount of a population with immunity, you then have what we call herd immunity, and the disease basically goes away because it has no one to infect.
So, is there a possible way that we could safely give enough people? It's not the right way of saying it, but if is there a way we could get herd immunity in the safest possible way? What would that be? How do we enable enough people to get this who will not die from it, so the disease won't have any place to live and we won't be concerned about it anymore? What do we need to do?
Sure. The only way to do that is to have people exposed. So the people you don't want exposed are those high-risk patients. So the elderly and people with significant underlying medical problems or immune deficiencies, you do not want them to be exposed. But certainly the young and healthy, we know the death rate in the young is extremely small. And
Hmm.
so having those people, live their lives routinely and get exposed on a regular basis, they're not going to, they're going to get sick. Some of them will, but the majority are going to just develop, flu-like symptoms and go on about their daily lives and develop the immunity, and that's how we're going to do it. But we have to be cautious about the high-risk groups. And some of the mistakes I think that have been made is closing the schools down and having all those little kids who may be infected go home to who's staying with their grandparents or staying with their immunocompromised family members. I mean, that's really the worst thing you can do is isolate people who are at high risk with people who aren't going to have any problems. So
I thought that's what the UK had done initially. They said it would be worse to send all the kids home and have them be in close contact with elderly parents or elderly grandparents. I think they may have ultimately closed their schools, but initially that's what they were saying, Dr. Dan. They were saying, like, if we do this, it's going to be worse than if we just keep the kids in school. And of course, in retrospect, who knows what the right policy will be? I know Sweden at this point has not done a lockdown. Do you have any data from that area, Dan? I haven't been able to look at it in recent days. I don't know if you have any new data from Sweden, but how are they doing?
Well, they're doing, their death rate, based on how we're calculating death rate currently, their death rate is around the 10%, whereas some of the other countries are 6 and 7. So their death rate is a little higher, but not substantially. I mean, when you look at total numbers, their total numbers really aren't that bad. But when you calculate how we're calculating death rate, yes, but they're going to develop herd immunity a whole lot quicker. So they're going to peak, and their incidence of a longer duration of this course is going to be less, and they're going to be able to open up and do more things more quickly than anybody else because of the approach they took.
By the way, in 10 or 15 minutes, we're going to open this up to questions for our viewers out there. So if you want to ask Dr. Daniel Eichenberger a question, you can just type the word question in big capital letters on the Facebook stream, on the YouTube stream, wherever you're watching, and we'll take a look at it. Just make sure your question is stated in complete English and it's succinct. And we'll try and get to your questions here, as I say, in 10 or 15 minutes. Dan, both Dr. Fauci and Dr. Birx, who are sort of the lead medical people that we see on TV about this, they're working with President Trump. They're from the CDC. They're saying that the reason the models have been wrong is because we're doing such a good job in the lockdown. Now, I think the original estimate that we'd lose between 2 and 2.5 million people, I think that estimate, to be fair, was if we did nothing, right? But
That's
subsequent models have said between 100 and 240,000. And I remember Dr. Birx saying this on March 29th. I don't know why I remember that date, but I remember her saying it March 29th, almost a month ago now. She said, if we do everything perfectly, we might be able to be at the bottom of that number, like around 100,000. In other words, the estimates that came from the models had the lockdown procedures that we would take baked in to the model. And yet the models were still wrong. So I don't buy into the idea here that it's just our lockdown that has caused a lower number of deaths. There must be something else going on. What else is going on here?
What else is going on is the natural history of the disease itself. I mean, we know that this type of virus historically again, this is a new virus, so we can't predict with 100% accuracy what it's going to do. But based on other seasonal viruses, we know they are going to decline on their own, whether you do anything or not. So the models are flawed, and the models have underlying bias. And we know that lockdown isn't what occurred in a lot of the modeling, because if you look at some of the states who didn't lock down quickly, their numbers are still lower than New York. I mean, look at California, look at Florida.
Sure.
You know, their populations, they did not lock down as quickly, but yet their numbers, you know, if the modeling was accurate, then you would anticipate Florida and California numbers to be higher than New York because they didn't lock down as quickly. So that's not the answer. So there's still something else going on. And again, I still say that's partly related to the natural history of the viral, you know, pathophysiology.
So we're on the back end of the bell curve now in terms of the number infected and number of deaths, as far as we can see right now.
Yes.
Based on the data. And the original models have been wrong. They've always been wrong. But everything's clear in retrospect, right? I mean, from a policy perspective, the president and the governors did basically what Dr. Fauci and Dr. Birx were saying we needed to do. We may look back on this several months from now and go, that was too drastic. We don't. It appears it probably was, but it seems to me that from a political perspective, the president was in a no-win situation. I mean, he had to lock things down. Otherwise, there could have been, if the models were correct, it would have been disastrous, right? And now we're seeing that the models were probably not correct. And he, and as, of course, several other governors want to start opening things up. And from what I'm reading, it's going to start opening up, particularly in places like Georgia, Tennessee, maybe a few other places this Monday. What is your view on that, Dan? I mean, if you were the president now, the president has to take not just the medical data into account, but as you mentioned before, he's got to take the economic data, which can lead to, of course, deaths as well, and the political calculus here. If you were the president right now, what kind of policy would you set in New York, and what kind of policy would you set in other areas less affected by this?
Sure. Even in New York City is still, they still need to have extreme social distancing and some other measures in place to help minimize the impact on the hospitals and the healthcare systems. But elsewhere in New York, they need to start letting businesses open back up with precautions, not just, you know, flip the switch and have everything back to where it was. I mean, the routine common sense approach of, you know, if you're sick, wear a mask. If you're sick, stay at home. If you're wanting to go out, you know, avoid huge groups of people, but certainly don't avoid doing routine life. We need some common sense, and we need to give the American people credit, not only for their common sense and good decisions, but they typically know what's best for themselves, and allow them some liberty to do that. This government, you know, we've lost liberties. We've been restricted, and we've actually lost some liberties through this coronavirus epidemic. I mean, you look at California. I mean, they filled a skateboard park with 32 tons of sand. You know, they're taking people off beaches that are there by themselves with no one around them for 50, 100, 200 feet. I mean, those people are not at risk of getting coronavirus when they're out there by themselves. And for us to have these draconian measures and these governors doing some of these really, really stupid things is uncalled for.
You know, there was a picture in one of the media outlets of a beach in, I think it was Florida, that showed, okay, the beaches are open in Florida, and they showed all these people all over the beach. Well, it turned out it was a file photo because the pier in the background had been wiped out in a hurricane. And they didn't even show the real picture of how many people were on the beach the day it reopened. So the media was giving the impression that the beach was more crowded than it really was, to try and further the narrative. Oh, these people aren't paying attention. They're not doing social distancing. It wasn't even a picture of what was happening that day. It just...
Well, and CBS got caught twice using the picture from an Italy hospital claiming it was a hospital in New York, and then the same picture they used and claimed it was a hospital in Pennsylvania. Even after they were caught the first time, they still used it a second time.
You've got to test all things, ladies and gentlemen. Some apostle back when said something like that. You've got to make sure you're getting the right information. Well, Dr. Dan, can you give us some perspective on the seriousness of the coronavirus? You have some numbers for us that can help us put this in perspective.
Sure. So, the highest risk group from what we've seen so far is over the age of 65. And interestingly, when you take that away, the next biggest risk factor is obesity. Now, certainly underlying medical problems, diabetes and hypertension and heart disease and lung disease are all there. But when you look at the data so far, obesity is a huge contributing factor after age. But when you look at the national statistics for the United States, over the age of 65, every year we have on average 54,312 people per 100,000 population die. When you add coronavirus patients over 65, you basically add 3.6 patients to that 54,000 that are going to die anyway. So coronavirus is adding, and so instead of 54,312 patients, you're going to have 54,315.6 patients die per 100,000 population. So
in what time period, Dr. Dan? What time period?
Yeah, that 54,000 is an annual number. The last data they had was 2017. That's the 65 and over age group, and the 65 and over age group for the coronavirus thus far is 3.6. per 100,000. So when you put it in perspective, older people after the age of 65, a lot of them die from a lot of other causes. So coronavirus, yes, it adds some to the number, but it's not a significant amount.
It's interesting. About 5 or 6 weeks ago, when you first came on the podcast, I asked you the question, do you think more people will die from the flu this year than coronavirus? And you said probably the flu. Do you think that's still going to be the case? It's going to be close.
It's going to be close. Yep.
Yeah.
And certainly, with influenza, we have a lot of other things with the flu shot, and people's already been exposed and immune to it. So, you wouldn't think that would be the case. But coronavirus is not going to be the overwhelming death that we were told at the beginning. It's a bad disease. Yes. I mean, you don't want to get it if you're 65 and older with underlying medical problems. But other than that.
Right. And the primary underlying medical problems you say are obesity, diabetes, lung issues, anything else? Well,
we're seeing asthma, and we're seeing underlying heart disease and hypertension as the key indicators for hospitalizations and worse prognosis. Okay. But the New York data really showed that obesity was a significant finding in these patients that got hospitalized. And the reason.
Go ahead.
Yeah, the reason for that is we think that obesity is an inflammatory factor in the body, and we know that inflammation is one of the culprits in this disease process. So the inflammatory response, just being obese, is significant.
Not Dr. Gavin Newsom, that's Governor Gavin Newsom out there in California, said, it must be week 10 days ago, Dr. Dan, that there will be no sports in California until a vaccine is available. What's your view of that?
Well, I can't believe someone would even say that with a straight face. There's no way you could do that. I mean, if he will have an uproar and, a retaliation from a number of people, including the players and the fans and the businesses. We're not going to see a vaccine, 12 to 18 months away. I mean, you cannot shut down the entire economy for 12 to 18 months.
But from a medical perspective, is it the right thing to do? Forget the economy why not?
Well, because again, you're just delaying the natural immunity that we get with herd immunity. So that's what we want to see. We want to do it as quickly and safely with as minimal impact as possible. But by completely keeping people away from each other is not going to be helpful. The only way we're going to win this war is herd immunity. That's the only way you're going to win this.
Mm-hmm. So it's not going to be a vaccine. And I've noticed, by the way, with the flu, there's a different vaccine every year, right?
That's correct.
I mean, are we going to get coronavirus 20 next year?
Likely we will.
Okay.
But again, we didn't see the SARS-1 virus, the corona, what they called SARS-1. We didn't see it come back. So again, there's only speculation whether or not this particular coronavirus will return next year. And it's up in the air. You can ask 10 people and you're going to get 5 say yes and 5 say no.
And what about a second wave? What's your view of that? Is that possible to happen in the fall, or is it likely to happen?
I'm not sure.
Where are we on that?
Well, I'm not sure a second wave you would refer to in the fall, because flu season starts in October. So, we would anticipate seeing influenza and these other respiratory viruses beginning in the October timeframe. Now, if you're talking about a second wave, you'd be referring more to a second wave in the summer months when you start decreasing the social distancing and other measures we put in place. We might see a
Oh, Dr. Dan just popped out, and he'll pop back in a minute. And once we get him back in, we'll go to questions. But I want to say one thing about this, Jorge, regarding the policy perspective here. The president, and Dan's coming back here in a minute, the president was ridiculously wrong when he said that he had the authority and nobody else had the authority. Now, he's backed off that in recent days, because the way our country is set up, we are the United States of America, and the states have the jurisdiction to govern on issues like this. The president obviously can set national policy, but the reason we have state governments is because we have different areas, different populations, different economies, different weather patterns in these different states. And so policy is best set at the local level. While you might have to shut down Manhattan, you don't have to shut down Montana in the same way. And this is called federalism. I know it sounds opposite of what it really means. Federalism means that the states and local governments should have more authority on these matters than the federal government. Now, the president is right to say, okay, we're going to stop immigration, or we're going to stop travel from China or Europe. That's his prerogative. But when it comes to applying policy at the local level, you need governors and local politicians or local representatives, in my view, and according to our Constitution, we need them to apply the appropriate measures locally. And that's why I think, as you were saying, Dr. Dan, we can open up different areas of the country without other areas being opened up, correct?
That's correct. And I do think that's where we made the biggest mistake to begin with, was having a one-size-fits-all policy starting at the federal government and telling everybody to shut down. We did not need to do that. The economic impact would have been substantially different if we would have taken a more directed approach to those targeted areas and allowed the Midwest Kansas and the Indianas that don't have problems, and Kentucky and Tennessee and all the other states that have minimal issues, allowing those businesses to continue working. And again, maybe helping us with herd immunity as they move forward.
Many of you have watched the program before. We've talked about this in a previous live stream and on the podcast as well, and yesterday with Scott Klusendorf. But let me just briefly say one thing before we go to your questions. When people are saying we want to open up the economy, and they're pro-life people, they're not saying that life is invaluable. What they are recognizing is there has to be an optimal approach to minimize death, because you don't just have death from medicine. You have death from the economic impacts of locking down the country. You have unemployment, which also often leads to stress and disease. You have untreated diseases that could be being treated or could be being diagnosed right now and are not being diagnosed because the country is locked down. You have domestic abuse rising. You have alcohol and drug abuse rising. You have people who were sober and are now not sober anymore because of this. You have surgeries that are put off and people die. In fact, Dr. Dan, you had that occasion in one of your patients, didn't you? What happened?
Yeah, so I had a bypass patient who was scheduled for an elective bypass who was put off because of the issue with coronavirus, and then he died of a heart attack prior to his bypass.
So you have all of these dominoes that fall. The ripple effect is true. If you shut down the economy too hard, you're going to create a ripple effect that's actually going to kill people in ways that you might not be able to trace specifically, but it does happen. And that's why you can't just have the medical professionals saying, here's all the policy, we're just trying to minimize medical deaths. No, you're going to get deaths and disease from shutting down the economy as well. And the president and the governors, they're going to have to make the call as to what's the most optimal way of not creating too many deaths from medicine or too many deaths from the economy. They're going to have to try and pick a middle road here. And that's, I think, where we're heading.
I agree. And we know that lots of policy changes that governments have made in the past, both state, local, and federal governments, even if you just look at a speed limit going from 55 to 70, they knew when they did that, there was going to be an increased number of deaths related just to increasing the speed limit. But they still did it. So evidently, it wasn't just about one life, as some of our governors are stating with the coronavirus.
Yeah, and when they increased the speed limit, they probably actually increased economic efficiency and had less food spoilage, less medicine went bad, because stuff could be transported more quickly. And you had a better economy, which a rising tide lifts all boats. So it's hard to measure, but we probably have had less deaths and less disease from having a higher speed limit than having a lower speed limit and preventing some of the accidents there.
That's correct.
So it's a trade-off. Sorry, go ahead, Dan.
Well, and the economy in the United States not only affects us here in the United States, but we support a lot of third world countries with all kinds of healthcare needs that prevents death in other countries. If our economy is weak, we are not going to be able to provide the support to these third world countries and other places that we do now. And so we're going to see a global death rate much higher, but that's difficult to, quote, pinpoint on the coronavirus shutdown. So you're not going to see that in the news, and certainly, but we know it's going to be an impact. We've seen already anti-anxiety medicines are up over 30%. Alcohol consumption is up. Relapses are already from drugs and alcohol significantly up. Depression, suicide. I just was on a meeting last week, and the chairman was a psychiatrist, and he said his last 8 admissions to the psychiatric unit all were related to depression from the economic issues.
Well, let's go to some questions for Dr. Daniel Eichenberger. We'll bring Jorge on, and he'll get to your questions. Again, put the word question in big capital letters, very succinct, to the point question. We'll try and get to as many as we can. Jorge, what do we got?
Hey, fellas. First, we have Lisa Quintana from Women in Apologetics. She's been in some of our shows. She asks, can we really get back to business as usual, or will we have to change our behaviors permanently? For example, handshaking is no longer our greeting.
So I think it's going to be a slow return to what we considered normal behavior in the past. How quickly that occurs will depend on individuals' risk tolerance. So handshakes, it's going to come back. It's going to come back quicker for some people than others. I was up at my office just last week, and one of my partners immediately reached out and shook my hand. The other partner, we did an elbow tap. So it's funny when you have 2 partners that you've worked with for 30 years, and they both have different approaches to the situation.
I sure hope it doesn't come back in church. I hate the shake your neighbor's hand part of the whole thing. I hope that's dead forever. Pastors, do you hear that? No more shaking hands in church. I'm done with it. All right, good.
Mike Riley says, I'm a teacher in New Jersey. Once we all go back to school in September, what do you think the chances are that things are carriers and spread it to all teachers and bring it home to their older family members?
I think that risk is going to be low. I think the more people we get exposed and the quicker we can develop some herd immunity, the less risk that will be. I think when teachers go back to school in the fall, I think there will be processes put in place with better hand washing, better hygiene, wiping surfaces down on a more routine basis. So I think the risk of that is going to be pretty low.
Great. I got Mary Reyes. She says, is it not better to just build your immune system than get vaccines, meaning healthy diet, supplements, A, C, D, zinc, etc.?
So the answer to that is most medical professionals believe that active immunity is better than passive immunity, but passive immunity is better than no immunity. So it is better if you can get a disease and develop your own antibodies, and your system recognizes that disease process internally, rather than the passive immunity. But if you're a high risk patient, you don't necessarily want to do that.
Okay. Benjamin Minton, there are so many opinions from specialists. How do we know who is giving us the correct information?
You don't, just like the mainstream media, you have to use your own knowledge and common sense and wisdom, and take the information, not take information at face value, but look for other sources and verify the information that you've been given and try and come up with your own decision based on what's out there. Certainly, if you have a question about a specialist's advice, get a second opinion. You will see that there are differing opinions on virtually everything in medicine.
Great. This one says, I keep hearing that the cure cannot be worse than the virus. At what point do we reopen? And if we do, is there a chance that we can deal with this each season just like the flu?
That is the goal, is to have this become more of a flu-like response rather than a pandemic-like response. So that is the goal long term. And again, I think his statement, is the cure worse than the disease? It's another statement similar to that is, well, the surgery was successful, but we lost the patient. We don't want to do that here. We don't want what we're doing. We don't want to lose our country because of what, we were successful in flattening the curve, but we lost the country because of it. We don't want that, or we lost our liberties, or, whatever else, you want to put in that sentence. We don't want that to be the case.
Billy Holly says, are not there multiple strains of corona that maybe a person could catch one and then later on catch another strain?
Yes, that question is a good question. Coronavirus does have multiple strains. And in fact, not only in humans, but in animals as well. And just like the influenza A and B, we have multiple strains of that. Back in 2009, it was H1N1 was the big issue. But every year we see different antigenic variations of the influenza virus and the coronavirus. This one just happened to be a coronavirus that we had never seen before in humans. So that's why it's different.
I see. This one, would it be wise to postpone a wedding reception for the end of June for 150 guests in Wisconsin?
I would say absolutely not. I would proceed with that wedding reception in Wisconsin in June.
Okay.
Hey, I could marry him on Zoom. I married my son and fiance on Zoom, so.
Yeah, actually, for all of those who are not part of the crossexamine.org email list, you missed today's email. It had a fantastic video. You can go to YouTube and check it out. And also the 30% off for the Logos Bible software. You missed that, but you can still go to logos.com/crossexamined to learn more. TL Frank asks, have you treated with hydroxychloroquine? Is that how you say it, Dr. Dan?
Yes, hydroxychloroquine. The brand name for that is Plaquenil, and it's been around a very long time. Typically, it's reserved for more high-risk patients, patients that have already, been compromised, maybe even on the ventilator. And typically, it's comes in a form where you give 400 milligrams initially, and then it's 200 milligrams twice a day is the current dosing for that.
Great. Marcos Valdez says, isn't this whole thing public health versus economic question? How do we decide which one is more important?
Well, that's a good question, and that has multifaceted answers and approaches. There has to be a healthy balance between the two, between the public health and the economic impact. And I think we, on this show, we at least agree for the most part that the the overall response we've done has probably been overdone for the public health aspect of it. The original goal was to flatten the curve. Now the goalpost has been moved. Now, every time you hear a governor, now it's to prevent death, now it's to prevent other things. But the original reason we did what we did was to flatten the curve and not overwhelm the healthcare system. Well, we were very, very successful in doing that. We did not overwhelm the healthcare system anywhere, even in New York City. Although they were strained and struggled at times, we did not overwhelm the system in New York. We were able to get the supplies and things needed for the most part. This has always been a logistics problem, getting the right people, the right equipment to the right places at the right time. We have never even come close to overwhelming the ventilator supply, the hospital bed supply, the ICU bed numbers. We've never even come close to doing that in the United States.
Right.
And we are also saying as well that it's a false choice between medical deaths and economic situation or economic impact, because what we're saying is that the medical impact, yes, people will die, but people will also die from the economic impact. So the two are related. We're not saying it's lives versus money. What we're saying, it's lives versus lives. And you've got to figure out what the right road to take is in between those two considerations, the medical impact and the economic impact, because both of them can kill people. So we're trying to figure out how to optimally deal with that. And that's why earlier in the program, we said it definitely is done better at the local level. You don't have to lock down Montana to lock down Manhattan.
And again, I think Dennis Prager had an interesting question that if the impact was in rural Montana, if that's where the highest incidence of cases and deaths were, do you think New York City would have shut down like we did?
Yeah, no, not at all,
No.
right? Yeah.
Yeah, I mean, so
It's
it's an interesting question, and I'd like to see some politicians actually try and answer that question.
Sam, as usual, with great questions, says, what are some of the biggest errors you two see in the way the media reports on this pandemic?
Well, the media reports based on emotion and sensationalism, and they only give you metrics that support the narrative they want to present, and they don't put it in perspective. Just like, here in Indiana, Kentucky, we have a governor in Kentucky that every day, we had this many new cases. Well, he didn't tell you how many cases they actually tested for. So yeah, if you're going to test 10 times the amount of people, you're going to have a higher number of positive cases. But if you don't put that in perspective and you only use the one metric, you are misleading people who are listening to you.
Great.
Yes, and for every story you see about somebody dying from coronavirus, as tragic as that is, you're never going to see a story for the more than 99 other people who got it and recovered. You're never going to see a story about that. You're just going to see stories about the downside, not the upside, and that's why you get a skewed view. That's why you can't have the peace that transcends all understanding by reading the New York Times or watching Fox News. You can't do it. You got to go to Philippians 4 for that.
Yeah.
And again, when you look at putting things in perspective, 54,000 adults over the age of 65 per 100,000 population are going to die without coronavirus. When you add coronavirus into the mix, you get an extra 3.6 of those patients per 100 population. I mean, yes, it's 3.6 more than what would have occurred.
And we have Dan out again.
So back in again. I think he was saying, and if that number is correct, I'm sure he's got the right number, but you're going to lose, what did he say, 54,000 per 100,000 of the population, or per million? I guess that's the question. Dan, what was the the units on that number? 54,000 per how many?
Per 100,000 population.
So more than half of the people over 65 die every year. Is that what we're saying?
No. Well,
because if you have 54,000 die.
Oh yes. Okay. Yes, you're correct.
Okay. So more than half of the people, 54,000 people, will die who are over 65 every year. Okay, that seems to make sense, right? If you took a lower age group, it would be a lot less, but you're talking people over 65. So more than half are going to die anyway. And what, Dr. Dan, if I'm following you correctly, only 3.6 more of those people will die due to coronavirus, according to the current stats.
That's correct. And when you look at that 54,000, and you look at the data, it's almost 28,000 of that 54 is above the age of 85. Which makes sense. So when you're talking about the 65 to 69 age group, it's only right at 3,000 out of the 54,000. So again, age is not on your not a good prognostic indicator for longevity. And when you think about it, I mean, the national age in the United States is 78.6 years. So once you're over 78, I mean, you've outlived life expectancy in the United States. So every year is a borrowed year in that regard.
Excellent.
Well, we're all vulnerable. This disease has made us feel more vulnerable, but we've always been vulnerable, and we don't realize that. We think that we're going to live forever here. No, we're not, until Jesus comes back and recreates the heavens and the earth, and then we will. Let's go to more questions, Jorge.
Well, first, before we get back to the questions, I want to thank everybody who are watching on Facebook and YouTube, on the website, on the app. You guys, we're having over 500 people live and thousands watching after a few hours. So thank you for sticking around and helping us keep a good retention rate. Keep your comments coming, and make sure that you share this, because this is important to get the message out there. Now, Joanna Osmack
and
asks,
wait a minute, I don't want people to go away too, because at the end we got an announcement to make. We got some big time guests coming up, so
all right,
keep watching.
Yeah.
Go
Make
ahead,
sure
sorry.
you stick until the end.
Yeah.
The question says, my son was extremely sick in January. In the same week, my husband and also my daughter, they are fine now. Should they get tested to see if their illness was corona? Would that be just wasting a test since they are fine now? Should we bother?
Well, so I do believe that we saw a lot of patients probably in January and February who had coronavirus, who didn't know they had coronavirus. And that family certainly sounds like they'd be a good candidate to have the antibody testing at some point. Now, if it's going to cost them a lot of money, it's not worth doing. But certainly for our knowledge base, understanding this disease and understanding who had it would be beneficial. So I'd encourage them to get the antibody testing done if it's available and if it's not going to cost them an arm and a leg.
And that would help them ease their mind once they can go back out in public, knowing that it's probably extremely unlikely that they could get the disease again, correct?
That's correct.
Yeah.
Okay.
I got Elo Sanchez Martinez says, what about the mask? The OMS said that only sick people should wear them. Is that an argument that is being ruled out already? Because everybody is using them, and I know she's in Dominican Republic right now, so they're just going up to the peak in terms of infection.
In some cases, some countries, some states, some cities are mandating a mask wearing. The most important people that should be wearing masks are those that are sick. So if you've got a fever, if you've got a cough, and you're going to be out in public, you should be the ones wearing a mask. If you're healthy with no symptoms and you're not going to be in a group of, dozens and dozens of people, the odds of a mask being beneficial is pretty low. If you don't have direct exposure to someone, the odds of getting the disease is still very low. It is a direct exposure disease for the most part, from what we understand right now.
Hey, I got a quick question from a friend from Brazil who just emailed me this question. Dan, have you treated with the hydroxy, I can't even pronounce it. What is the way to pronounce that?
Yeah, hydroxychloroquine.
Hydroxychloroquine, Z-Pak, and zinc. Have you treated anybody with that triage of treatments? And what kind of results have you seen?
Yes, and we saw improvements in their respiratory status. They came off the ventilator and they did well.
Okay, good, because my friend who's a missionary down there says that's hope for us overseas without quick access to medical care.
Yeah, and I guess just to elaborate on that to some degree, there is some evidence as far as immune boosting things that people can do. Zinc is one of those vitamins that seems to be helpful for lots of viral illnesses, along with vitamin C in quantities of about 4,000 to 6,000 milligrams a day. And vitamin D is really significant, and that may be one of the reasons why the black population may be having more difficulty with coronavirus, is because of the melanin in their skin prevents them from developing vitamin D from sunlight as easily as Caucasians do. So vitamin D supplementation is also something. So between vitamin C, zinc, which one did I miss? Vitamin D, and also selenium, all have been the 4 different things that you can use to help boost immunity.
What is Z-Pak? What is that, Dan?
Z-Pak is an antibiotic called azithromycin. It typically is used for bacterial infections, not viral infections.
Yeah. Got a good question here, and I don't know what's the position of the questioner, but he says, what makes you qualified to answer these questions? Are you an epidemiologist or an infectious disease doctor? How can you speak with authority on this?
Sure. So that's a good question. So I am a physician. I've been a practicing physician for 30 years. I am board certified in both adult internal medicine and pediatrics, and I've taken care of patients in the inpatient and outpatient hospital settings for my entire career. So I've taken care of patients in the office as well as patients in the ICU. So I've dealt with all kinds of patients across all disease processes. A lot of times we don't have specialists for all the other areas like he described, in infectious disease and other things. So we have to manage those on our own a lot of times.
Great. Larry McPherson says, do you think this will somehow bring back businesses to America from China? Because we've seen that's happening in Japan, I think.
I'm hopeful that we become less reliant on foreign countries, especially China, for our supply chain. Whether that'll happen, again, there's a lot of ramifications for that. China can do it cheaper than we can do it here in the United States, so we need to be willing to pay more for the same things we've been getting at a less cost because of the China employees that they don't pay hardly anything to.
And some of these considerations must take into account national security. You can't have for example, all your steel coming from a foreign country, because what happens if you need it in a time of war? You can't have all your antibiotics, like apparently we have 90% of our antibiotics coming from China. What happens if they cut all that down? So there has to be some policy to a certain extent that would ensure that we have national security or medical security by having either those products made in the country or with very strong allies, it would seem to me.
Sure. Any business that has an IT infrastructure has what we call redundancy. So if something goes down, they have a redundant system somewhere located in some facility, usually outside their own, that can be a backup. So again, putting 100% of our reliability on a single entity, single country is not a good decision on our government standpoint or a business standpoint.
Before we wrap this up, Jorge, I want to mention, and we're going to get to let Dan close it out here in a minute, but I want to mention in the coming days, ladies and gentlemen, tomorrow we're going to have Dr. Gary Habermas on to talk about doubt, especially when you go through doubt, a period of darkness. What can you do about it? Gary's going to be with us tomorrow. On Thursday, we're going to have Greg Kokel, his new updated book, Tactics. We'll talk about how you can talk to people about Jesus, which is what you ought to be doing, especially now when people are more open to it. On Friday, we're going to have Dr. William Lane Craig on to talk about the arguments for Christianity. And, Dr. Craig is probably the top apologist, or one of the top in the world right now. Next week, we're going to have people like Max McLean, the current day C.S. Lewis, who you've probably listened to on your Bible because he's the voice of the NIV narrative Bible, and he does some great plays with regard to C.S. Lewis. We'll also have J. Warner Wallace on. We're going to have Elisa Childers on. We're going to have David Wood on, all coming next week, so you don't want to miss any of that. And don't forget, until tomorrow night, there are discounts on the Logos software and also an early bird special on the Stealing from God premium course, which will begin teaching in May. But that's only through tomorrow night. So go to crossexamine.org, click on online courses to see more about that course. Dan, can you just wrap it up with some hope for the people that are watching here? Because our hope ultimately isn't just in medicine, it's in a lot more than that.
Sure, I think so. As Christians, we need to remember that we are not a body with a soul, but we are a soul with a body. And even though we may die on this earth, our soul will change locations. I think, as our friend Frank always says, we don't necessarily die, we just change locations. So we do have eternal life as a guarantee for us, and that's where our ultimate hope needs to be.
Dr. Daniel Eichenberger, thank you so much for joining us. I'm sure I hope this doesn't last very much longer, but we may have to have you on again just for another update. So thanks, Dan. Thanks for what you're doing, and thanks for helping those patients wherever you're going. I know you're helping people all over Indiana, and next week you're going to Michigan to help people. So thanks for the work you're doing.
Yep, thank you.
Thank you, guys,
Thanks,
and see you tomorrow.
All right, same time. See you then. God bless.